My name is Heather Brandt, and I direct the HPV Cancer Prevention Program at St. Jude Children's Research Hospital. I'm pleased to serve as the moderator for this panel session, The Atmosphere Matters, Current Data on Insurance and Geography as Determinants of HPV Vaccination. In this session, the presenters will share information about how where we live affects HPV vaccination rates, including recent research findings on effective interventions in rural communities, and explore how immunization registries and geographic data mapping can target areas of low vaccination. Yesterday, we learned about HPV vaccination in diverse racial and ethnic communities, and where we live matters too. The atmosphere matters. The context matters. And importantly, the presenters will discuss how we take this research on key HPV vaccination determinants and apply it for action at the state level. Geographic disparities are significant in HPV vaccination. In this map of the United States showing recent NIS team data, you can see the discrepancies, especially in the South and Intermountain West. Across the South, in particular, Mississippi has the lowest uptake of HPV vaccination at 30.5%, and Louisiana has the highest at 59.5%. The mean across southern states is about 49%, which is a full 5% lower than the US average. So while there have been improvements, geographic disparities persist. Rates can also differ significantly within a state, territory, or jurisdiction. If I were to show you a map of HPV cancers in the US, you would see in these areas with the lowest HPV vaccination uptake that there are the highest rates of HPV cancers. We must identify regionally appropriate strategies to account for the uniqueness in geographic regions with low HPV vaccination uptake to prevent HPV cancers. To take this one step further and integrate insurance coverage, there are 12 states that have not yet expanded Medicaid, with 8 of these in the southern US. A recent study published by Hoff et al. On the association between state Medicaid expansion and HPV vaccination showed significant increases in HPV vaccination after states expanded Medicaid. The largest increases were among individuals below the federal poverty level and among those with below $75,000 annual family income. In another recent and related study, Hawkins et al. Found provisions of the Affordable Care Act to be associated with increases in HPV vaccination series completion. And the results of this study suggest expanding Medicaid across the remaining states could increase HPV vaccine completion among publicly insured youth and prevent HPV cancers. HPV vaccination coverage in rural areas has been consistently lower as compared to urban areas in the US. From 2013 to 2018, the magnitude of the disparity between mostly urban and mostly rural areas did not improve, settling at the current difference of about 12.4 percentage points. Coverage was significantly lower among teens living in mostly rural areas, regardless of poverty status, sex, and race ethnicity, except among Black non-Hispanic adolescents. We are all more than one thing at any one time, and this is important to note when considering how we approach HPV vaccination interventions with rural communities. One of the presenters from whom we will hear today, Dr. Whitney Zond, led a review study to examine intersectional identity in rural communities to better understand the influence on cancer disparities more broadly. This work builds on work Dr. Zond has conducted previously in rural populations and cancer, including HPV cancers. Rural populations have an increased incidence of HPV cancers compared to urban populations and have experienced a statistically significant increase in HPV cancers. There also are differences within rural populations. Back to the point, we are all more than one thing at any one time. This means we have to consider local data sources, such as immunization registries, to target our efforts in rural areas. Dr. Natasha Askelson used data from Iowa's State Immunization Registry to examine the relationship between location and HPV vaccination initiation as one example to identify areas for targeted interventions. Now, add in characteristics of people and places, and well, the atmosphere matters, and it matters a lot. We see differences in HPV vaccination across geographic regions and within them, such as in rural spaces and across the people who live there. So let's transition to the presentations for today's session. In today's session, you will hear from researchers who will reflect on the role of geography in HPV vaccination. These researchers have looked at key determinants, including rurality, area level factors, and insurance status, to consider factors that complicate or facilitate HPV vaccination. You'll also hear from ERA, the National Organization of Immunization Information Systems, about how stakeholders can leverage data for their own work. The bios for each of the presenters have been provided, and the presenters today are Dr. Bernard Femmler at Virginia Commonwealth University, Dr. Whitney Zond, at the University of Iowa, and Courtney Londo with the American Immunization Registry Association, and me too. Not only am I a moderator, but also will be presenting. We'll have just a short 10 minutes for conversation at the end, so be ready with your questions. What we can't answer live, we'll capture for later. I'll be presenting on HPV vaccination interventions in rural U.S. communities to share the results of a narrative review I conducted with colleagues. In the background leading up to the presentations for today's sessions, I shared information on rural communities. Many barriers to HPV vaccination have been noted in previous research in rural communities. Low levels of HPV vaccination knowledge, lower overall childhood immunization rates, uptake of adolescent and adult vaccinations have also been shown to be lower. Healthcare provider shortages, lack of healthcare provider recommendation, and lack of transportation and distance. These and other barriers do not operate in isolation. They work together to create major barriers to action. To date, the majority of HPV vaccination research in rural U.S. communities has used non-intervention study methods such as qualitative research, observations, surveys, and secondary data analysis to assess HPV and vaccine-related determinants. This research has been very important to understand the landscape of factors associated with HPV vaccination for descriptive purposes, but has resulted in limited guidance on how to increase uptake of HPV vaccination through interventions in rural settings. In contrast, the more broadly characterized HPV vaccination intervention research has shown that there has been less of a focus in rural communities. Rural communities are special to me. I grew up in rural northeastern Iowa in a small town with about 1,000 people called Fairbank. My upbringing shapes my work today as I reflect on my own experiences with rural communities and those of my many family members who still live there today. I'm reminded of the numerous strengths of these places, often thought of as remote, isolated, under-resourced, and more negative characterizations. There are so many strengths in rural communities: resiliency, self-sufficiency, assets indicative of collective strength, hardiness, and more. These are important, notable strengths that make up the fabric of rural life. However, these same strengths may make someone living in rural America less likely to seek preventive care. And this is particularly important with preventive actions such as HPV vaccination. So overall, for HPV vaccination interventions, there's this blend of evidence-based and recommended approaches focused on ensuring supply and generating demand. And these approaches work best in combination and are multi-level and multi-component, even multifactorial aspects within components to accommodate for context. So here is a snapshot of recommended approaches from the community guide. So while these evidence-based interventions may work generally, what about in rural US communities? What do successful interventions look like in rural US communities? The National Cancer Institute has emphasized a need for investment in rural cancer control, and HPV cancers are higher among people living in rural areas with lower HPV vaccination rates. So, what do we know about how to change this? These factors led to our narrative review to examine intervention studies to increase HPV vaccination in rural settings and to summarize these study characteristics and outcomes. In our narrative review, we use systematic narrative review methods for studies describing implementation of HPV vaccination interventions in rural US settings from 2006 to 2019. 15 studies met the inclusion criteria and were published from 2011 to 2019. These studies reflected multi-level approaches across patients and parents, healthcare providers and settings, and communities. And the intervention approaches included educational and communication strategies, provider recommendation, and addressed access to HPV vaccination. There were varying types and levels of engagement. The two most common approaches in rural settings were to address healthcare providers and systems and focusing on provider recommendations as a key determinant. Multi-level and multi-component interventions allow for implementation of myriad strategies to overcome barriers and enhance facilitators to HPV vaccination in rural settings. And there has been considerable emphasis on individual level barriers, but less so on environmental and system level barriers. Our review revealed mismatched evaluation approaches that did not correspond with the multi-level approaches. As Blake et al. And others have reported, the complexity of conditions in rural communities require equally complex interventions to address these disparities. Multi-level approaches consider resources, cultural values, geographic location, and economic status, among others. Implementation across multiple levels without evaluation of some sort across these levels limits the value for future replication and scalability. So for HPV vaccination intervention research, the desired behavioral change most appropriate to include is an HPV vaccination outcome, which was a requirement for inclusion in our study. But we found a need for greater consistency in measurement and reporting. There was tremendous variability in measurement and reporting that resulted in challenges in being able to even compare outcomes across studies demonstrating statistically significant results. Consistent measurement and reporting across multiple levels and for multiple components will aid in helping us to understand the most effective approaches to increase HPV vaccination in rural settings. Across the 15 studies, no study explicitly defined rural, and few provided important contextual information on the rural setting. This creates challenges for future replication and scalability. Reporting on these contextual factors, including those in the social, physical environment, the policy environment, and then among individuals, will strengthen our ability to apply these approaches in other rural communities. Another area of interest for increasing uptake of HPV vaccination in rural areas has focused on policy change. And policy changes can provide structure to support practice and shift social norms. To remove such barriers and increase HPV vaccination in rural areas, policy measures are needed with the ultimate goal of decreasing those disparities. So here we conceptualized policy change to occur across multiple levels and used big P and little p designations, understanding that both have the potential to increase HPV vaccination. Our efforts to increase HPV vaccination with rural communities are urgently needed, given the elevated rates of HPV cancers and low rates of HPV vaccination uptake. Strengthening the evidence base by accounting for rural context and also using what has been shown to work in other settings, being thoughtfully adapted for implementation in rural settings, can guide these efforts. Here I've summarized the many opportunities for improvement with rural communities. There's more attention being paid to HPV vaccination in rural settings. And we know there are emergent areas of research, including the role of social media, telehealth, and learning from vaccination approaches during the COVID-19 pandemic. In conclusion, we need more intervention research with rural communities and also better intervention research. Intervention research that accounts for context and is going to provide guidance on how to ensure approaches account for the strengths of people and place in the rural US. To reduce the burden of HPV cancers in rural settings and improve low HPV vaccination uptake, we need to understand methods and outcomes of HPV vaccination intervention research with rural communities. Rural populations are not monoliths, and our intervention approaches should not be either. So we must ensure we put what we know into widespread practice with rural communities, and we are considering their unique needs and context. Thank you very much for this opportunity to talk about HPV vaccination in rural settings. We hope you'll reach out to engage with us in the St. Jude HPV Cancer Prevention Program. Thank you.